Behavioral economics, you're going to love that term once we get done with this episode. It was a fascinating topic for me to explore. And it really is, I think, at the forefront of the foundation for all the technologies that we're rolling out. It's at the forefront of changing behaviors in the community and population health. And I think you'll agree with that. One of the things I wanted to make you aware of, and one of the things I'm really enjoying, is I've started a conversation on LinkedIn. And what I do is every morning I get up around 5:30. I collect a couple stories. I decide which one I'm going to talk about. I put a story out there, and I write what up to the limit of the number of characters that you can do. And we've had some great conversations going back and forth. So if you're not following me, please do that. That is one way that you can engage in the conversation. And again, the back and forth has been fantastic, and I want to invite everyone to be a part of that. Also, you can follow the show over on LinkedIn. That's another area where we are investing significantly to upgrade. And if you haven't checked out the YouTube channel lately, we have really updated the YouTube channel, categorized everything. And this is the benefit of having sponsors. I have a team of people that is working really diligently to make this stuff accessible to you. And to your teams. So thanks, and I hope you enjoy this episode. Welcome to This Week in Health IT, where we amplify great thinking to propel healthcare forward. My name is Bill Russell, Healthcare CIO coach and creator of This Week in Health IT, a set of podcasts, videos, and collaboration events dedicated to developing the next generation of health leaders. This episode and every episode since we started the COVID-19 series has been sponsored by Sirius Healthcare. Now we're exiting that series, and Sirius has stepped up to be a weekly sponsor of the show through the end of the year. Special thanks to Sirius for supporting the show's efforts during the crisis and beyond. All right, today we are going to explore a topic that is really interesting to me. This is actually, I'm going to say up front, this is not a paid episode, because sometimes people are like, oh, you're bringing on a consulting firm. Is this a paid episode? It's not. This is such a fascinating area for me, and I think it is going to be for our listeners as well, which is why I have Karen Horgan, the co-founder and CEO of VAL Health, on the line. And VAL Health is a behavioral economics consulting firm. Good morning, Karen. Welcome to the show.
Good morning. Thanks for having me.
This is one of those topics I've always wanted to talk about, and as we were talking about earlier, until you can get me to stop going to McDonald's, I'm going to be a health risk. Right. And that's what behavioral health and behavioral economics is really about, changing behaviors. Give us an idea of what behavioral economics is and what your firm does.
Great. I will tackle that. And afterwards, we can have a longer conversation about McDonald's and how to drive your specific behaviors. And we can create a whole plan for you. Anyway, thank you again for having me. Behavioral economics is a science of understanding that humans are irrational. We have biases to the present, which is why we eat the chocolate cake when it comes around on a dessert tray. We have aversion to loss and regret. That's why we hold on to houses or stocks that we should be selling off. We overweight probabilities and spend over $70 billion a year on lottery. So behavioral economics is that science that we now understand how humans are going to behave. And rather than trying to get people to not behave that way, what we can do in healthcare is acknowledge those irrationalities and decision biases and incorporate them to drive specific behavior changes.
So are you saying we're predictable in our irrational behavior? Is that what you're saying?
I'm saying that, yes. And so we know that we have certain tools in our arsenal that if you make the right path the easy path, because we're lazy, we're going to stick with the default. How many times do you watch a binge on Netflix? Because they just give you 6 seconds to roll right into the next episode. We know that we're social beings, especially during COVID. We've all seen this. That we like to do what others are doing, and we like to see them to see what we're doing, and we model our behavior after them. So let's use that to our advantage and good. Let's not be like the gambling companies. Let's not be like McDonald's to try and get people to eat supersize your French fries, and try and use it for our good.
So let's you're going to talk to us about how health systems can apply this to the good, and how digital startups can apply this to the good, which I assume are the types of clients that you work with. But let's talk about the bad, because there's a lot of people trying to get us addicted to, checking our phone often. Apps try to get us addicted to things, and food tries to get us addicted to things, and gambling tries to get us, not tries to, but has the unintended consequence of getting us addicted to things. Is this science used on both sides of the equation to pull me in one direction and then we need to start to strengthen the muscle on the other side to pull us in the other direction?
The short answer is yes. The longer answer, which won't be too long, is that behavioral economics has been a science that's been around 40, 50 years. And it has been used in finance. It's been used in retail. It's been used in gambling. It's been used in so many ways to get people to do certain things, to buy three for $1. So you're going to buy three when really you could just buy one for 33 cents. Or the gambling machines, the slot machines, they know exactly how long you're going to be playing until you're about to give up. And they give you a little bit of a win, which gives you a little optimism bias. And so healthcare has been very slow to the game to bring in behavioral economics, because in healthcare, the industry as a whole, I'll call it stubborn, has always thought, well, we're just going to give people information and that is going to drive change. We're going to tell them how many calories there are in a Big Mac. And data shows people purchase the same number of calories before and after. But if our team went into a Subway sandwich shop and changed the order in which items were listed, so part of the day low-calorie items listed first, the other part of the day high-calorie items listed first, people purchased 25% fewer calories when low items were listed first. And so healthcare has just not played on the fact that we're lazy and we do all of that, and we need to start doing
it. I mean, that's interesting. So you're saying we do lean pretty heavily on the education side. We think if we educate people that they're all of a sudden going to start making the right decisions. Like if people knew that a 2,000 calorie diet was, for somebody of I've looked at this way too many times for me, but a 2,000 calorie diet is what I should have, and I should exercise this much. And I mean, I don't need any more information, but still I struggle in those areas, but still healthcare keeps trying to educate me on the things I think I already know.
Think about mammograms and colonoscopies. With the Affordable Care Act, colonoscopies were free. People aren't running out and getting their colonoscopies, like even once you remove the cost. Or mammograms are only about 57% of targets, the right women are going to get their mammogram, even though you're going to give facts that it can save lives. But that information doesn't just drive behavior. And 40% of our chronic conditions, this is pre-COVID, so statistics probably will change, are brought on by lifestyle, because we literally want to eat our cake and be healthy too.
All right. So we have a significant challenge that's going to be facing us here shortly, which is vaccine, right? So there's going to be a vaccine that comes out soon. And so is that the kind of thing that somebody would come to your company and say, look, we need to get somewhere in the neighborhood of 65%. We have this many that distrust, this many. I mean, we have the statistics. We know what it is. And people, I know some people who are in public health and whatnot are scratching their head today going, I don't know how we're going to get to this 65, 70%. Is that the kind of thing your organization does?
That would be spot on. So my co-founders are Kevin Volpe and David Ash. They are academics at Wharton School. Dr. Volpe runs the NIH-funded Center for Health and Science and Behavioral Economics, and Dr. Ash is heavily involved in Penn Medicine's Nudge Unit. And so they have the raw science that's been published in peer-reviewed journals, New England Journal and JAMA, and we at VAL Health bring this out into the real world. And I recently read an op-ed from a great economist saying that the government should pay every American $1,000 to go get their vaccines. And I wanted to pull my hair out, because I think that is the worst idea we possibly could do as a country for a couple of reasons. One, what's the statistic? 30, 40, 50% of people say they're going to go get a vaccine anyway. So you're paying them for what they would have done. So that's going to cost us $150 billion. As the other half are now going to do some decision tree in their head of the government is trying to pay me because they think this isn't a good vaccine and there's going to be all kinds of side effects, and they're trying to bribe me with $1,000. And that's completely irrational. And so what we know we need to do on the vaccine side is you need to have local presence and campaigns. So I live in the New York City area. If you have the mayor or governor here doing a campaign and they air it in Texas, it's going to make no sense. So you need to find local communities, and the vaccine needs to come down to the local level of you're doing it for the safety of your community, you're doing it for the reopening of your community. It's not about the broader country, and it's not about the broader globe. People are going to respond more to personalization. We know that.
So it's community organizations, it's places of worship, it's grocery stores, it's local drugstore. I mean, it's those kind of things.
It could be the It could be the quarterback of the football team, like if NFL, like if you're in Green Bay, and the Packers are. I don't know why I'm picking on the Packers, but they're everyone loves the Packers. Have the team talk about it, and that you find something that's central to the community, and personalization, and you're doing it for others, and that's going to drive people to do the right, which I think is the right thing.
So what do people, what are the question I'm really going to dive into here is, what are the tools in your tool belt? Is story one of those things? Is it pictures? If you had the picture, I mean, I'm picturing an ad of the Green Bay Packers with a full stadium and with an empty stadium, and essentially painting this picture of, we want you back in the seats. And in order to get back in the seats, we need everyone to step up and, go get a vaccine.
Yep. So the tools in our toolkit, and I love that. I think I should call the Packers. I hadn't thought about this until right now, and I'm not a Packers fan, so not sure where that came from. So if you think about the main tools we have in our toolkit, one is choice architecture, which is how do you make the right path the easy path? And we know that if you change defaults, people are going to stick with that. I already mentioned Netflix, and we've seen this work in healthcare to get people to complete health risk assessments, to get people to schedule appointments, all of that. The second tool in our arsenal is around framing. We know words matter. Losses are more powerful than gains. We know that if you use common language, it makes you get a much bigger impact. I mentioned we're social beings, so social elements. We've used social proof, for example, with Mount Sinai in New York, again, pre-COVID, and got a 5 percentage point reduction in patient no-show rates by explaining to people that the norm was people show up for their appointments. And then the third tool in our arsenal is financial incentives. And financial doesn't just mean I'm going to pay you X to earn Y. A lot of the financial component could be framing around if there's no cost share, or what the benefits are, and how do you frame that? Because we know if you anchor people, it makes a big difference. If you're going to buy a car and they tell you for $30,000 you can get this car that has the winter package and all the bells and whistles, or for $29,000 you lose the winter bells and whistles, people are going to stick with the 30 because they're anchored there. But if you start at $29,000 and you have to spend an extra $1,000 to get the bells and whistles, they're not going to do that. And so if we know if you anchor people, if you have quick wins around the financial component, that makes a difference.
All right, let's talk about engagements. So I want to head in two different directions. One being a digital startup, the second being a health system. And it sounds like you've partnered with Mount Sinai in some of the work that you've done. And so let's go down that path first. Where do they typically engage you? Do they come to you with a problem, with a hypothesis, like, or do they come to you with a problem like, we need to get the vaccine out, and you go, okay, let's start to design some programs?
The first projects we tend to do in an organization is more of the latter of, we have a specific problem. If we need people we worked with Sutter Health. Their problem challenge was, we want our patients to use our portal more. And they threw that at us. So we looked at what are the components and the features that people can do. And we ultimately honed in on, we're going to drive people to schedule appointments online, because it's a patient satisfier. Like, I can do this at any hour, and it saves cost, because each time the patient calls in, there's a cost to someone handling that. And so we focused on using email communications to drive people to schedule appointments online. And they had 4.9 times as many people using the portal and scheduling appointments. And so there was a specific problem that they had. And then we advanced. The next one was, we want more women to go in for their pap smears and closed capsule care. And we more than doubled the rate at which women did that. And so it's almost easier for a health system to think about a specific problem that is a behavior change. It could be a provider behavior change or a patient behavior change. And then let's bring behavioral economics to do that, because the organization has probably tried for years just telling people are doing the same thing over and over.
And, one of the things is, we're talking to technologists, and one of the mistakes we've made over the decades is essentially, if you build it, they will come. Right. So we're going to build a portal. We're going to build this really cool technology. Yeah. We're going to roll out this program that's for the good of the health of our community. Maybe not a technology thing, but with the health system, how we think. But the reality is, we should really wrap almost any kind of thing that we're looking at changing behaviors, either internally, how people use an EHR, externally, how people engage our system. We should wrap that with some aspects of behavioral economics.
That is so well said. So we look at it as, you can retrofit or you can bring behavioral economics in from the start. So if you think of digital health companies, some of them we work when They're really early stage, and behavioral economics is just core to their strategy. They're always thinking as they're designing it, how do you make the right path the easy path? How do you eliminate steps in enrollment? How do I use the buttons in the right way to frame it so people want to take action? But usually what happens more often than not is they come to us later on and they're like, well, we've built it and no one's coming. And then we call that the retrofit and wrapping behavioral economics around it. And a lot of it's in the communications, and then sometimes it is enhancing the journey as well.
Do you work with digital startups? So I was a chief information officer, but I also did the digital side, and we had a couple of startups. And it would seem to me that you would want to bake a lot of this into the user experience. Does this get caught in the sort of user-centered design, or does it really have to be broken out and thought about how are we going to get people to engage with this tool?
Oh, the right way should be part of user-centered design. But usually what is happening now is, and I mean this with all respect, that people have an idea for a startup and the founders are entrepreneurial and creative and they build it to their best of their ability. And it's kind of new, it's interesting, but then ultimately it's not getting the engagement that they and their investors want. And that's when we come in. And I get it, because if you're an entrepreneur like I am and you think you know what you're doing, you're not going to bring in an expert from the beginning. That being said, there are a couple startups that are just in concept phase that we are working with now. And it's more fun for us because if you can get behavioral economics done right from the beginning, it's going to be that much more powerful than putting it as a Band-Aid.
Why? So talk to me about social media tools. So TikTok's in the news right now, being bought by Oracle, an acquisition I do not understand and cannot explain to anyone who's asked me. But so you have TikTok, you have Facebook, you have LinkedIn, and it's kind of funny because every week my phone sort of shows me, hey, this is how much time you've engaged with your phone. And it just cracks me up because I think I'm cutting back, and every week it goes up a little bit. And so there's sort of this, they've sort of locked into this. They know how to get me hooked into scrolling through the entire feed or watching these videos, even though it's a waste of time. And you touched on Netflix a little bit there. I mean, can we do that same thing in health? Can we ever get to that point where it becomes sort of a habit forming thing where I'm exercising and I'm dieting and all those things?
So I'm going to take maybe a controversial statement on that. I actually think we want to get to the point where you don't have to be thinking about your health, but you're actively doing that. So let's take exercise off the table for this part of the conversation. But if we want people to be tracking their blood sugar or checking their blood pressure and all of the things that go into managing chronic conditions, there's a concept that Dr. David Ash and my co-founders coined called automated hovering. How can we use technology to take away steps that we're asking people to do? Like, can you wear one of these kind of trackers that I've got on my wrist that will tell me if my blood pressure gets too high? Or are there ways that you can track my blood sugar if I'm diabetic without me having to think about it, and you only alert me to when I need to know? So that way I can live my life with my chronic condition, and you're using technology in a way to proactively tell me. And then there's the designing for exercise. There's also things such as if you've got diabetes and you want to eat the pizza, go eat the pizza. And they're going to tell you, well, if you eat that pizza, go for a 15-minute walk after to counter it. And you might be willing to do that because you're like, okay, I really want to eat that pizza. I can go for a 15-minute walk. And so it's breaking it down into bite-sized pieces that can help nudge and create new habits.
This is one of those, Bill Russell just asking a question because I'm curious. I've seen health systems who like hand out tools. They like give them away. Yeah. Is there something about investing in the tools that when people actually have paid money for a Fitbit or whatever, that they're more prone to use them?
The short answer, I don't have data behind this. I like to qualify because I'm a very data-driven person. You're more likely to start using it, but it doesn't mean that you're going to stay engaged. So you kind of have extrinsic, intrinsic motivation. And if I go spend money on my Fitbit, it shows up, I've already exhibited the fact that I'm interested in using it because I've gone and purchased it and it shows up. Great. You're hitting on an interesting point that if my health plan just sends me something, I never asked for it, I might not even open the box. I'm not intrinsically motivated, and so I might not use it. The longer term implications could end up being the same, but if you actually spend the money, you're more likely to start using it. And we actually work with a lot of health plans who do send these remote monitoring devices to people or even in COVID, trying to get people to do close gaps at home and send the kits back. How do you actually get people to follow through when they never asked for it?
So is this research going on all the time? Or are you asked to do some research as a result of these projects?
So we, as a consulting company, I would not call us a research organization. That being said, when we work with our clients, if they can A/B test, that is fantastic for us because it's a real world test. Like with Sutter Health, we were able to A/B test with hundreds of thousands of patients. And when we worked with Blue Cross Blue Shield of Louisiana, there was tens of thousands of members. And so we can then take those learnings and bring them out to healthcare in a greater sense, because then we know how people are acting in the real world.
So just to clarify, A/B testing, just give us an idea of what that is.
Yes, great. So some of our clients are, for example, already sending their standard letters out to the members, and then they'll send their letters, and then a second group of members will get the letters that we've crafted with behavioral economics. And so version A is theirs and version B is ours.
Absolutely.
It's a real world test.
And we've been doing that in marketing for years, right? So it's just it's a way of testing two different methods against each other. This is such a fascinating topic. I mean, we can go in so many different directions. What are some of the mistakes that health systems just make? Well, I mean, let's package them up real quick of, what's the top 5 mistakes that we make as we go out there and try to change the behavior of people for the good of the community, for health, right? But what are the mistakes we make?
It's a great question, because people don't knowingly make mistakes. And I actually think you said it well, that they think they're doing the right thing. And we'll look at it and say, well, that's a mistake. So for example, health systems will offer 17 options to people. You can to manage your conditions, or here's all the different things you can be doing. Well, that's a concept called choice overload. And we just shut down and we make no decision. And so what they really should be doing is giving you 3 options. And then literally, if they want to have the rest of them, have you literally double click or ask for more, so not taking away choice. But we're more likely to take action if there's limited. The other thing they do is they use technology that actually makes things more complicated. So I was speaking to someone the other day, and he said, but it's very interesting. He's like, in healthcare, all we do is add technology on top of technology on top of technology, and we never break it down and just start over. And so it ends up being so kludgy. And that is something we do. We don't step back and say, well, how is this from the member experience? Like in healthcare, using technology is the opposite of using Amazon or my phone or any of that. Yesterday, I got an email from my health plan saying you have a new summary. I don't even know what a summary would be of, so they're not using common language. I click on it because I'm curious, because of Karen. And then I need to know my username and password, which I've forgotten. And then I try and reset it, and they tell me I have to call a phone number. It's just, we're hiding behind HIPAA and privacy and not trying to actually still make things easy. The other thing that hospital systems regularly do is they don't use common language. They use language that maybe the doctors understand, but the patients and the consumers don't understand. And so we're less likely to take action. The study that was done, not by our team, but that's interesting, is if smokers go in for a lung capacity reading and they're given the results in a numerical format that means something to the physician, 6% of them quit smoking a year later. If instead they're given a lung age of your 28-year-old male, the lungs of a 42-year-old, 13% quit smoking a year later. So double the number quit smoking when they get it. And so using the common language, figuring out the user experience is something that health systems can really improve on.
Yeah, it's interesting. Well, I mean, we're caring for my father-in-law here. He lives with us, and we'll get these bills, and he'll go, "Oh, I got a bill today." I'm like, "No, that's not a bill. It's an explanation of benefits." But to him, it's like, it's a bill. It should, And I sort of sat back and I thought, okay, it doesn't explain anything. And it doesn't really add any benefit whatsoever. It's an explanation of nothing. It's like, it's added confusion. And so health systems are like, I don't know why my AR is so high. Well, nobody understands what we're supposed to pay. You've made it so complex. I don't know am I supposed to send money in now? How about now? How about now? When am I supposed to send you the money? It's so crazy.
And then they tell you amount billed $5,000, our price $2,000, you owe $74, this amount. None of it makes any sense. Like, why is there different numbers?
They're just numbers. And to my father, actually, I'm in the industry, and I've only really run across maybe 2 health systems that have really attacked this problem and done it well, where they said, we are going to make these very understandable. And they ran into so many challenges along the way in terms of regulatory and compliance and other things. But they plowed through in order to make it better for the community. But so few have done it. It's hard work.
We've worked with a couple hospitals on their bills because they wanted to reduce their bad debt. And it was, how do you communicate to people? Sometimes the bad debt they found out was people just didn't know they actually were supposed to pay because they get all these other things that they're not supposed to pay. And so we worked with them on how to simplify the statement to communicate specifically what they owe and why, and also using common language and what they're getting billed for, as opposed to the ICD-10 codes. Use something that people understand, of like MRI of your knee. And they're rolling it out now. So I don't have the results, but it's quite interesting to see how hospitals recognize that they can reduce bad debt that way.
Well, we've talked a little bit about language, and this is probably my last question. Let's talk about language a little bit, because we use a lot of inside the door kind of language, inside the hospital door language. But then we set up these call centers, and they're interacting with patients, and they're still using that language. Do you end up working with organizations around their language and how they approach their consumers?
Yes, that is a great question. So we regularly work on crafting sound bites for call centers to use, either around specific behaviors or just in general. So we worked with One Blue Plan on the West Coast, and they wanted their members to select a PCP and to have a attributed PCP. And when their members were calling in, they were encouraging people to do that, and they weren't getting the results. We came in and we changed, like, I think it was 7 words. And we doubled the rate, where they went from 16% to 32% of people selecting the PCP on that phone call by changing those 7 words. And I bring that up partly because they looked at us in the end and they said, we paid you for 7 words. And my answer is, well, we literally doubled your impact, and you didn't have to change your processes or anything. It was just changing a soundbite that was in there. And we changed it to a default concept of, oh, I see you don't have a PCP. Which of these 3 do you want? And people selected one of them.
Oh, that's so. Behavioral economics is so powerful. It sounds like, because you know why I'm making the decisions I make. And, if we get you involved earlier in the process, you can help us to maybe get to be a lot more efficient quicker.
That's right. Because the way we approach this is we focus in on what are the behaviors you need someone to be doing. What are the hurdles to doing that behavior? It could be awareness. It could be the obstacles that I need to my member ID. I need to know how to download an app. Then what are the touch points we have to reach you? And then how do we intervene? Can we change to make the right path the easy path, change the default? How do we bring in the words? How do we bring in social proof and nudges and get you going? And again, we use it for good, not for bad. So
thanks for coming on the show, Karen. I really appreciate it. How can people get more information about this, or follow you, or what? How can they get more information?
You can follow me on LinkedIn. I regularly post. It's Karen Horgan, and you can sign up. We do monthly insights at VAL Health, where we send out behavioral economics insights. So you can go to www.valhealth.com and sign up for the monthly insight and keep learning. And I encourage you all to try and bring this into your day-to-day life, or ask yourself, what can I do today to make the right path the easy path for my customers or my stakeholders or whomever they are?
Yeah, that's fantastic. I really appreciate it. Thanks again, Karen. And I look forward to following you and staying up to date on what you guys are doing in behavioral economics. Thank you for your time.
Thanks for having me.
That's all for this week. Don't forget to sign up for our clip notes. Send an email, hit the website. We want to make you and your system more productive. Special thanks to our sponsors, our channel sponsors, VMware, Starbridge Advisors, Galen Healthcare, HealthLyrics, Sirius Healthcare, Pro Talent Advisors, Health Next, and our newest channel sponsor, McAfee Solutions, for choosing to invest in developing the next generation of health leaders. This show is a production of This Week in Health IT. For more great content, you check out our website, thisweekhealth.com, or the YouTube channel. If you want to support the show, the best way to do that, share it with a peer. In fact, sign up for clip notes, get those emails, send them on to your team members, peers within the industry, and let them know things that you have been getting value out of. Please check back every Tuesday, Wednesday, and Friday for more shows. Thanks for listening. That's all for now.